Welcome back to The Deep Dive, the show that, well, digs into the essential knowledge on complex topics, hopefully making you the most informed person in the room.
Glad to be here.
Today, we're tackling something pretty intense from the world of critical care. Fat embolism syndrome, or FES. And we're starting with a statistic that honestly sounds pretty wild. If you have a major fracture like your femur, your thigh bone, apparently microscopic fat globules get into your bloodstream something like 90% of the time.
90%? Yeah, that's a staggering number. It sounds almost inevitable after a big trauma like that.
Right.
But here's the really crucial point we need to get across right at the start. That 90% figure, that's just fat embolism, just the fat being present in the bloodstream.
Okay.
Most of the time, it causes absolutely no symptoms. It's clinically silent. People don't even know it happened.
So the fat's just kind of floating around in there, and we're fine.
Often, yes.
Okay, so our mission today is to figure out the difference between that common, often harmless event and the thing that's actually called fat embolism syndrome, FES, because that's the one that's, well, dangerous, right? The serious complication.
Exactly. That distinction is absolutely critical. Our sources define fat embolism, the common thing, as just the physical presence of those tiny fat globules, often mixed with some bone marrow cells, in the blood vessels right after the injury. Think of it like debris getting into the plumbing.
Got it. Plumbing debris and fat embolism syndrome, FES.
So FES is what happens when that debris triggers a whole systemic crisis. It's the term we use for the small minority, maybe, estimates vary, but around 1% to maybe 10% of those major fracture patients who actually get really sick from it.
And it doesn't happen right away either, does it?
No, that's key. It typically shows up 1 to 3 days after the initial injury. And when FES does develop, it's serious. The fatality rate is often cited as being somewhere between 5% and 15%.
Wow. Okay, so 90% get the fat emboli, but only a fraction get the syndrome, and that syndrome can be deadly.
Precisely. It's the difference between, say, a bit of sand in a pipe versus that sand somehow triggering a chemical reaction that corrodes the entire system. We need to understand how the fat gets in, and then crucially, why it sometimes turns toxic a couple of days later.
Okay, let's definitely unpack that. Let's follow the journey of that fat right from the bone breakthrough to potentially causing the systemic chaos.
Sounds good.
So we know the main trigger is usually a big fracture along bones like the femur, tibia, maybe the pelvis, sometimes, rarely, even major burns or just extensive soft tissue damage. But let's focus on that broken bone. What happens mechanically right at that moment?
Okay, picture the inside of a long bone. It's not solid rock, right? There's the marrow cavity filled with this mix of fatty tissue and the cells that make blood hematopoietic cells. And it's all crisscrossed with blood vessels.
Like a network inside the bone.
Exactly, a very vascular network.
Yeah.
Now, when you fracture that bone violently, you don't just break the hard outer shell. You also rupture those delicate blood vessels, the sinusoids and small venules inside the marrow cavity.
Ah, okay, so there's an opening now from the marrow into the bloodstream.
Right. And think about pressure. The marrow cavity is suddenly disrupted.
Yeah.
If the bone fragments move, or even just from the trauma itself, the pressure inside can spike. This pressure difference pushes the marrow contents, especially the fatty adipose tissue, literally out through those ruptured vessels and into the venous system. It's like it gets squeezed out.
It herniates into the vessel, as the sources say, like squeezing toothpaste into a vein. That's a vivid image.
It really is. And because all venous blood flows back towards the heart and then gets pumped to the lungs.
The lungs are the first stop. That's where these fat globules first get trapped.
That's the typical first site, yes. The pulmonary vasculature acts like a filter. And it's important to remember, like you said, it's not just pure liquid fat. It's often a mixed fat globules, maybe some of those blood-producing cells, bits of debris from the fracture, a complex little package.
Okay, so the fat gets squeezed into the veins, travels to the lungs, and gets stuck. That makes sense as a mechanical blockage. But that brings us back to the mystery. If it's just a physical blockage, why is the syndrome relatively rare? And why the delay? Why does it hit hardest a day or two later?
Exactly. The mechanical blockage is only part of the picture. Maybe the initial part, but not the whole story of FES. This is where we get into the dual pathogenesis.
Yeah.
It starts mechanical, but it becomes, well, a biochemical assault.
Dual pathogenesis, okay, two mechanisms working together.
Essentially, yes.
Yeah.
Though the biochemical part is really what drives the severity of the syndrome.
Let's break them down. First, the simple one, the mechanical obstruction theory.
Okay, this is the intuitive part. You have these relatively large microglobules of fat, maybe clumped together with some red blood cells and platelets that are stuck to them. They physically travel through the bloodstream and lodge in the small blood vessels. primarily in the lungs,
Blocking the flow.
blocking the flow. In really severe cases, maybe if there's a massive amount of fat, or if the person has a heart defect, like a small hole allowing blood to bypass the lungs.
A patent foramen ovale, or PFO?
Right, something like that. Then these emboli could potentially get into the systemic circulation and block tiny vessels in the brain, for instance, the cerebral microvasculature.
So that immediate blockage could explain maybe some sudden breathing problems or neurological signs right after the injury?
It could contribute, absolutely.
Right.
But like we keep saying, doesn't explain that delayed systemic inflammatory meltdown that defines FES, appearing 24, 48, 72 hours later.
Right. So that leads us to the second theory, the one you said really drives the severity, the biochemical injury theory.
This is where it gets much more complex and dangerous. This is how that seemingly inert fat becomes toxic systemically.
Walk us through that transformation. How does ordinary body fat turn into a weapon?
It's a chemical process. Once those fat globules are lodged, especially in the lung capillaries, the body starts trying to break them down. Enzymes in the blood, specifically lipases, begin to work on them.
Like digesting the fat.
Exactly. It's a process called hydrolysis. And when these lipases break down the neutral fat molecules, they release something else. Large quantities of free fatty acids, or FFAs.
Okay, free fatty acids, FFAs, why are they the bad guys here?
Because FFAs, in high concentrations, are directly toxic.
Sure.
They act almost like detergents at a cellular level.
Yeah.
Their main target is the endothelium.
The endothelium, that's the lining of the blood vessels, right? That super thin single layer of cells.
Precisely. It's incredibly important, but also very delicate. These FFAs cause direct toxic injury to those endothelial cells all over the body where the blood circulates. And when you damage the endothelium on a widespread scale, well, that's catastrophic.
Why? What does damaging the endothelium do systemically?
Think of the endothelium as the barrier controlling what stays in the blood vessel and what goes out into the tissues. When it's injured everywhere, it becomes leaky. You get massive vascular leakage. Plasma fluid starts pouring out of the blood vessels and into the surrounding tissue.
So swelling everywhere.
Essentially. In the lungs, this leakage floods the spaces between the air sacs, causing severe edema fluid buildup. That directly leads to respiratory failure. It looks a lot like ARDS, acute respiratory distress syndrome.
Okay, that explains the breathing problems. What about the brain?
Same principle. If the leakage happens in the brain's microvasculature, you get cerebral edema swelling in the brain, which contributes heavily to the neurological symptoms we see.
And this widespread damage must trigger the body's alarm systems too, right? Inflammation.
Oh, absolutely. That endothelial injury is like a massive body-wide distress signal. It kicks off an intense inflammatory response. You get platelet activation, and aggregation platelets get sticky, clumped together, which uses them up and can worsen blockage. But critically, it triggers a huge influx of inflammatory cells, particularly granulocytes.
Granulocytes, we hear about those in infection and inflammation, neutrophils and the like.
Yes, neutrophils primarily. They're the body's first responders, armed and ready. The problem is, when they arrive at these sites of FFA-induced endothelial damage, they don't have a specific target to attack. So they just degranulate. They release their entire arsenal of potent, damaging chemicals systemically.
What kind of chemicals? The sources mention specific things.
Yeah, three main categories come up: proteases, free radicals, and eicosanoids.
Okay, break those down. Proteases.
Proteases are enzymes that chew up proteins. They literally digest tissue components, adding to the structural damage.
Nasty. Free radicals.
Think reactive oxygen species, highly unstable molecules that damage cell membranes through oxidation. They attack healthy cells, including any remaining intact endothelium, worsening the injury.
And eicosanoids, that's less familiar.
Eicosanoids are signaling molecules derived from fatty acids themselves, things like prostaglandins and leukotrienes. In this context, they're really bad news because they dramatically amplify the inflammation. They promote vasodilation, making vessels wider, and critically, they increase vascular permeability even more. They basically crank up the leakiness that the FFAs started.
Wow. Okay, so let me see if I've got this biochemical cascade right. The fat lodges, lipases break it down, releasing toxic FFAs. FFAs damage the endothelium, making vessels leaky. This damage calls in the granulocytes. The granulocytes release proteases, free radicals, and eicosanoids, and those chemicals cause even more widespread damage and leakiness.
You've got it. It's a perfect storm, a vicious cycle that feeds itself. The initial mechanical event triggers a chemical catastrophe that spirals out of control.
And that explains the delay. It takes time for the fat to break down, for the FFAs to build up, and for this whole inflammatory cascade to really get going.
Exactly. That's why the patient might seem okay, maybe even stable after their fracture repair surgery, and then suddenly crash 1, 2, or 3 days later. The biochemical bomb has been ticking.
Chilling. Okay, let's pivot to how this actually looks clinically. When the syndrome does develop, what are the signs clinicians are watching for? What does FES look like in a patient?
Right. Diagnosing FES is primarily clinical, meaning it's based on recognizing a pattern of signs and symptoms in the right context, usually after that long bone fracture. There are specific criteria like GERDS or Schoenfeld's criteria that try to standardize it, looking for major and minor signs. But fundamentally, it's about dysfunction in 3 key areas: lungs, brain, and blood, plus that characteristic skin sign.
Okay, let's take those one by one. Lungs first, pulmonary insufficiency. You said this is often the first sign.
Almost always. Since the lungs filter that initial wave of emboli and are ground zero for the FFA release, respiratory symptoms usually appear early. We see a sudden onset of tachypnea, breathing really fast.
Trying to get more oxygen in.
Right. And dyspnea, the feeling of being short of breath, difficulty breathing. Plus tachycardia, a rapid heart rate as the heart tries to compensate for the poor oxygen exchange. This can get very bad very quickly, often needing mechanical ventilation as that inflammatory edema floods the lungs.
Okay, rapid breathing, shortness of breath, fast heart rate. Then the brain neurologic symptoms. What happens there?
The brain effects can be just as sudden and severe. It often starts subtly, which is why it can be missed initially. Things like irritability or restlessness. The patient just isn't acting right.
Not just pain-related agitation.
It can be hard to distinguish initially, but it progresses. It can rapidly worsen to confusion, full-blown delirium, disorientation, and in the most severe cases, seizures or even slipping into a coma. This reflects that microvascular blockage, the effects of those inflammatory mediators crossing into the brain, and the cerebral edema.
So that sudden mental status change, maybe a day or two after the fracture, in someone who seemed okay, that's a huge red flag.
Massive red flag. Then there's the third system, the blood itself, the hematologic changes. 2 key things here: anemia and thrombocytopenia.
Anemia, low red blood cells. Is that just from the initial blood loss from the fracture?
That's part of it, sure. Trauma causes blood loss. But in FES, it seems to be more complex. There's evidence that red blood cells can clump together, aggregate, because of the altered blood flow and inflammation. And some sources suggest there might be a low level of hemolysis too, red cells actually getting destroyed by the hostile environment created by the FFAs and free radicals.
Okay, so multiple factors hitting the red cells, and the thrombocytopenia, that's low platelets, right? Why does it happen?
Yep, this is really key. It's thought to be a consumption process. Platelets are designed to stick to damaged surfaces or foreign things in the blood. They see these fat globules coated with inflammatory signals as something to stick to. So they adhere, they aggregate massively, and they get used up or cleared from the circulation, often by the spleen. You see a rapid, sometimes dramatic drop in the platelet count.
Platelets getting consumed, and that directly leads to the skin sign you mentioned, the rash.
Exactly. That rapid drop in platelets is what causes the petechial rash. This is a really helpful diagnostic clue, though it only appears in maybe 20% to 50% of FES cases.
What does it look like? And where?
It's a rash of tiny, pinpoint, non-blanching red or purple spots. Non-blanching means if you press on them, they don't disappear. You most often see it on the upper body, chest, neck, shoulders, in the armpits, sometimes even on the conjunctiva, the whites of the eyes.
And why does low platelets cause these specific spots?
Platelets are essential for plugging tiny, everyday leaks in our smallest blood vessels, the capillaries. When the platelet count plummets acutely, like it does in FES due to that consumption, these capillaries start to leak small amounts of blood into the skin. That's what creates the petechia. Because this specific type of platelet consumption is so characteristic of FES after trauma, seeing that rash along with the lung and brain symptoms is highly suggestive.
Okay, that triad lung problems, neuro changes, petechial rash appearing 1-3 days after a long bone fracture is the classic picture of FES.
That's the classic triad, yes. Though not all components are always present, especially the rash.
Now, you mentioned diagnosis is mainly clinical. But what if you needed to prove it pathologically, say in a post-mortem examination or for research? Our sources mention a specific challenge here.
Ah, yes, this is a classic pitfall in pathology. If you want to see the fat globules in the tissue, you can't use standard processing methods.
Why not?
Because standard tissue processing involves fixing the tissue and then embedding it in paraffin wax so it can be sliced thinly. To do that, you have to use solvents, typically things like xylene.
And xylene dissolves fat.
Completely. It washes the lipids right out of the tissue sample. So if a pathologist looks at a routinely processed lung slide from an FES patient, they'll just see the inflammation and damage. But the actual fat globules, the initiating cause, will be gone. They'll see empty spaces where the fat used to be, if they look closely, but the fat itself is invisible.
So routine methods actually erase the evidence.
Pretty much. It means the diagnosis can be easily missed pathologically if you're not specifically looking for it the right way.
How do you look for it the right way then? What's the special technique?
You have to bypass those solvents. You need to use frozen sections. The tissue is snap frozen and sliced while still frozen. Then you use special stains for fat lipophilic stains like oil red O or Sudan black. These stains specifically bind to lipids, coloring the fat droplets bright red or black, making them clearly visible under the microscope against the rest of the tissue.
Fascinating. You need a specific technique just to visualize the very thing causing the problem.
It highlights how FES can be, in a way, a hidden entity pathologically unless you suspect it and use the right tools.
Okay, let's shift to managing this beast. Given everything we've discussed, the mechanical blockage, the runaway chemical inflammation, the multi-organ failure, is there a magic bullet? A specific cure for FES?
Unfortunately, no. That's the really tough part. Because it's such a complex, self-amplifying process involving both physical emboli and this diffuse inflammatory response, there's no single drug that can just shut it down. Treatment remains fundamentally supportive.
Supportive care. Meaning?
Meaning you focus on supporting the patient's vital organ functions, keeping them alive, and giving the body time to hopefully clear the fat emboli and resolve the inflammation on its own. It's about managing the consequences, not curing the root cause directly.
So damage control, essentially. What are the main goals of that supportive care, especially with the lungs and circulation failing?
Top priorities are maintaining adequate oxygenation and hemodynamic stability, keeping the blood pressure and circulation going. For the lungs, that means aggressive oxygen therapy, often very quickly progressing to mechanical ventilation.
Putting the patient on a breathing machine.
Yes, and often requiring specialized ventilator strategies, similar to those used for ARDS, things like low tidal volumes to avoid causing further ventilator-induced lung injury, sometimes higher levels of PEEP, positive end expiratory pressure, to help keep the fluid-filled air sacs open.
And what about the circulation given all that vascular leakiness you described?
That requires really careful fluid management. Patients often become hypotensive low blood pressure because so much fluid is leaking out of their vessels. They might need large volumes of intravenous fluids, crystalloids or sometimes colloids, to maintain volume, but you also have to be careful not to overload them, especially with leaky lungs. It's a fine balance.
And if fluids aren't enough?
Then you move to vasopressors, medications that constrict blood vessels to help maintain blood pressure and ensure vital organs are getting enough blood flow. You're essentially managing a severe trauma-induced systemic shock state.
Okay, so treatment is really about intensive life support. That makes prevention sound even more critical. What's the main thing that can be done to stop the embolism from turning into the full-blown syndrome?
The single most important preventative measure, backed by pretty strong consensus, is early surgical stabilization of the long bone fractures.
Yeah.
Getting that broken bone fixed promptly.
How early is early?
Ideally within the first 12 to 24 hours after the injury. Doing that significantly reduces the incidence of FES.
Why does fixing the bone help so much?
It goes back to the mechanical trigger. An unstable fracture where the bone ends can move acts like a pump. Every time those fragments shift, more marrow content, including fat, can be squeezed into those ruptured vessels. Stabilizing the bone, whether with plates, screws, rods, or external fixators, stops that ongoing pumping action. It limits the total amount of fat that gets embolized into the system in the first place.
Stops the continuous infusion of the trigger material.
Precisely. It minimizes the initial insult.
Doesn't the surgery itself, like putting a rod down the middle of the bone, an intramedullary nail, involve messing around inside the marrow cavity? Could the surgery itself cause an embolism?
Ah, yes. That's a really important point and a known risk. The surgical technique does matter. Intramedullary nailing, especially if the surgeon uses a technique called reaming.
Reaming? What's that?
Reaming is when they basically drill out the marrow cavity to widen the canal, allowing them to insert a larger, stronger nail. While that provides excellent stability, the act of reaming significantly, albeit temporarily, increases the pressure inside that bone marrow cavity.
So the very act of drilling to fix the bone could potentially squeeze more fat out into the circulation right then and there.
Exactly. It can cause a sudden shower of emboli during the procedure itself. This is a well-recognized phenomenon. Surgeons are very aware of this risk.
How do they manage that risk then?
There are techniques. For instance, using unreamed nails in certain situations, which are inserted without drilling out the canal first, or employing specific venting techniques during reaming to try and relieve that pressure buildup. It's always a balance, a need for strong, stable fracture fixation versus the risk of increasing embolization during the procedure, especially in patients considered high risk for FES like those with multiple fractures or existing lung problems.
Wow. So the orthopedic management is directly tied into this systemic risk.
Incredibly tightly linked.
Okay, let's talk about one specific treatment controversy: corticosteroids. Steroids. Given that FES is driven by this massive inflammatory reaction, like FFAs, the granulocytes, all those damaging chemicals, it seems intuitive that a powerful anti-inflammatory like a steroid would help, right?
That logic is exactly why steroids were proposed and studied for FES, historically and even now. The idea makes perfect sense. Damp down that excessive destructive inflammation. Steroids stabilize cell membranes, reduce the release of those inflammatory mediators. They should work, theoretically.
So why aren't they just standard practice? Why the controversy?
Because the clinical evidence is just messy. It's really mixed and inconclusive. Some older, often smaller studies suggested there might be a benefit, particularly if steroids were given prophylactically, meaning preventatively, before symptoms start, maybe even before the surgery in high-risk patients.
The idea being to nip the inflammation in the bud.
Exactly. Block the cascade before it really gets going. But larger, more robust studies and meta-analyses looking at all the data haven't consistently shown a clear benefit across the board.
Why so inconsistent?
Several reasons. Studies use different doses, different timing of administration. Is it truly prevention or just early treatment once subtle signs appear? Plus, FES patients are often complex trauma patients with many other injuries, confounding factors, making it hard to isolate the effect of the steroid itself. And of course, steroids have their own side effects, like increased infection risk or issues with wound healing, which are major concerns in trauma patients.
So where does the consensus lie now?
The general consensus currently is that corticosteroids are not routinely recommended for either the prevention or the treatment of FES in all patients. They might still be considered in very specific, high-risk individual cases by some clinicians, but they are definitely not a standard, universally accepted part of the management.
It really underscores how hard it is to treat something with both mechanical and complex biochemical roots.
It really does. There's no easy pharmacological fix when the pathophysiology is this complicated and involves such a variable host response.
Okay, so wrapping this up, it's been quite a journey. From a simple bone break, potentially leading to this devastating systemic failure.
It's a sobering reminder of how interconnected the body's systems are.
If we had to boil it down, the key takeaway seems to be this dual nature, right? The fat embolism itself is common, maybe 90% occurrence after major fractures, often silent.
Right, that's the initial mechanical event.
But the fat embolism syndrome, FES, the dangerous part, is much rarer, but driven by that secondary biochemical assault, the toxic free fatty acids triggering widespread inflammation and endothelial damage.
Precisely. It's not just the physical blockage, it's the chemical firestorm that follows, which causes the life-threatening organ failure, particularly in the lungs and brain. That's the critical distinction.
And for anyone listening, especially if you work in healthcare or might encounter trauma patients, recognizing those potential signs, the sudden breathing trouble, the confusion or restlessness, maybe that specific petechial rash appearing 1 to 3 days after the injury, that vigilance seems crucial.
Absolutely crucial. Because while we don't have a cure, early recognition allows for prompt initiation of that intensive supportive care, which is the patient's best chance of surviving until the body can recover. It buys time.
Okay, before we finish, let's circle back to something you mentioned, the hematological changes, specifically that massive consumption of platelets leading to thrombocytopenia and the petechial rash. Platelets are fundamental to blood clotting, right?
Absolutely. They're the first responders for stopping bleeding, forming the initial plug.
So here's a final thought to leave our listeners with, connecting FES back to the bigger picture of trauma care. If FES involves this rapid systemic consumption of platelets and widespread damage to the blood vessel lining, releasing all these inflammatory mediators, doesn't that sound a lot like the setup for another critical condition we see in severe trauma or sepsis?
You're likely thinking of DIC, disseminated intravascular coagulation.
Exactly. If FES is chewing up platelets and activating the clotting system all over the microvasculature due to inflammation and endothelial damage, how does the body stop this from tipping over into full-blown DIC? Isn't there a massive risk that this process not only causes clots, but also consumes all the clotting factors, leaving the patient unable to stop bleeding from their original injuries? It seems like you could be clotting and bleeding at the same time.
That is an absolutely critical point, and yes, the overlap and the risk are very real. FES can precipitate or certainly exacerbate a DIC-like state. You have widespread microvascular thrombosis, tiny clots forming everywhere, driven by the inflammation and platelet activation.
Adding up clotting factors.
Exactly, consuming platelets and other coagulation factors. At the same time, the patient has major traumatic injuries that are prone to bleeding. So they are absolutely put in this incredibly dangerous state of potentially having microclots impairing organ function while also having a systemic lack of clotting ability, leading to uncontrollable hemorrhage.
A true coagulopathy nightmare.
It absolutely is. Managing a severe FES patient often involves managing this complex coagulopathy simultaneously with the respiratory failure and shock. It's trying to balance anticoagulation maybe for the clots while giving blood products to stop the bleeding, all while supporting failing organs. It's one of the ultimate challenges in critical care.
Yeah.
FES isn't just lung and brain failure. It can become a total failure of the body's hemostatic system.
A truly systemic crisis triggered by, initially, just a broken bone. That really puts the severity into perspective. Thank you. This has been incredibly insightful.
My pleasure. It's a complex but vital topic to understand.
And thank you all for joining us for this deep dive. We'll catch you next time.